From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Well, hello, this is Dr. Linda Brubaker, an associate editor with JAMA and a professor at the University of California, San Diego, the Department of Obstetrics, Gynecology, and Reproductive Sciences. And I'm joined by Professor Chappell and Professor McManus, two authors of two separate manuscripts on self-blood pressure monitoring during pregnancy.
I'm Richard McManus. I'm a family physician and Professor of Primary Care Research at the University of Oxford.
I'm Lucy Chappell. I'm a Professor of Obstetrics at King's College London and a Consultant Obstetrician at Guy's and St Thomas's NHS Foundation Trust.
Thank you both for leading this work. Could you tell us a little bit about why you designed these two trials, Bump 1 and Bump 2, and the context of this important work?
I have been studying self-monitoring of blood pressure for just about 20 years, doing the first trials in the UK outside of pregnancy, and then moving on to self-monitoring and self-titration of antihypertensives outside of pregnancy. And about 10 years ago, I started thinking about pregnancy, and soon after that, joined up with Lucy for the studies that we have here. And Bump 1 came out of initial thoughts that maybe self-monitoring might detect raised blood pressure in pregnancy earlier than antenatal clinics, which in the UK vary between 1 and 4 weekly. We had an opportunity to do a second trial, and I'll ask Lucy to talk about that.
The idea for this trial really came out from a combination of the clinical need that I saw in front of me as a consultant obstetrician, paired with the expertise of Richard McManus, who had done so much work on self-monitoring of blood pressure outside of pregnancy. We wanted to examine what the evidence base was for self-monitoring of blood pressure in pregnant individuals with hypertension, to ask whether this intervention made a difference to clinical outcomes. And the work was underpinned with really strong development work to see how this intervention would work best, and then went into the trial as described.
Hypertension is quite an issue, and there's growing awareness that hypertension in pregnancy increases the risk of adverse pregnancy outcomes, and adverse pregnancy outcomes increase the risk for an individual later in their life, including stroke and long-term hypertension and cardiovascular events. So it is an important aspect, and pregnancy is a window to health. Looking at this, I think, is important. It's estimated that approximately 10% of pregnancies worldwide are affected by blood pressure problems, elevated blood pressure problems. And of course, globally, this translates to just a huge number, about 18 million pregnancies worldwide. So self-monitoring and blood pressure management has grown outside of pregnancy, but hasn't been used extensively inside of pregnancy because of the lack of evidence. Is that correct?
Yes, it's remarkable really that much of our practice in pregnancy care doesn't always have the evidence base that should be underpinning it, whether it's interventions like self-monitoring of blood pressure or drug interventions. And so this was a real opportunity for us to do a well-conducted trial in these two sort of separate but linked groups to really ask what the effectiveness was of this intervention.
So in the Bump 1 trial, you enrolled participants who were at risk for hypertension. And in the Bump 2 trial, you enrolled those who had chronic hypertension or developed gestational hypertension. So two different groups. Let's focus on the Bump 1 trial first. How did you define people who were at risk for hypertension?
Well, in the UK, the guidelines for monitoring blood pressure, which are set by NICE, which is the main guideline body in the UK, suggest that if you have one major or one moderate risk factor for hypertension or preeclampsia, that you should have more frequent blood pressure monitoring. And that isn't well defined, but we felt that appeared to be quite a good group to use to try out the self-monitoring. So listeners might be familiar with these sorts of risk factors in the context of aspirin. And certainly in the UK, for aspirin, you need one major or two of the moderate risk factors. So it's that kind of group. And it includes actually a lot of individuals in pregnancy because it includes people in their first pregnancy, but it also includes individuals with a previous history of hypertension, those who are older, those who are more obese, those in a twin pregnancy, and so on. That's that kind of risk factor.
And the intervention that was used in Bump 1 required participants to take their blood pressure 3 times a week, 2 readings a minute apart, and use the second reading, and they were connected through an app. And that technique for intervention had been piloted in a prior pilot. Is that correct?
Yes, that's right. We had done previous work outside of pregnancy and found that a simple regime, getting people to measure their blood pressure twice and use the second reading, because the second reading tends to be a little lower on self-monitored blood pressures, was a straightforward thing that by the time we did the trial, many thousands of people had done. We asked individuals to measure their blood pressure 3 times a week on the basis of some pilot work that we did. And we gave them some flexibility so that they didn't have to do it precisely the same time of the day and so on. We just asked them to fit it around their schedules, because obviously individuals in pregnancy are often very busy, so we wanted them to be able to do this. And importantly, we used validated monitors, and there are actually surprisingly few blood pressure monitors that are validated in pregnancy, so the monitors used in this trial were all properly validated.
Of the 96% of individuals who participated, quite a few were randomized, but there was no difference in the primary outcome, with about 15% in the intervention group and about 15% in the usual care group being diagnosed with clinic hypertension.
Yes, that's right. So in the Bump 1 study, that's what we would expect for those at increased risk of pregnancy hypertension. And we also looked at the time to recording of clinic hypertension. Of course, we needed to use an outcome of clinic hypertension because we were only receiving readings from those allocated to self-monitoring in a formal way. So at the same time to diagnosis for clinic hypertension for the primary outcome. But there were some interesting post-hoc analyses which explored this in more detail.
So the trial was powered to detect 12 days earlier. And how did you decide that that was the clinically significant window to use?
That was quite a pragmatic decision, as you can imagine. We wanted something that would be clinically significant. And as I mentioned earlier, individuals who are pregnant in the UK are seen between 1 and 4 weekly, usually, unless there's some really quite serious thing going on. So we thought that detecting a little bit earlier than a fortnight would actually make a difference to the women's care, particularly allowing earlier intervention. Now, that was balanced to a certain extent against the number of individuals that we could reasonably randomise in the trial. And that allowed us, in a trial of around 2,400 people, to have a primary endpoint that we thought was likely to be clinically significant.
But what's been really interesting about both trials is that we've gained far more understanding about women's home readings and women's clinic readings to an extent that we just hadn't really seen in the literature before these trials. So, for example, 61% of pregnant individuals who had a raised blood pressure on or before clinic hypertension had raised home readings with a median time of 29 days before their first raised clinic reading. So I think this group of individuals who develop hypertension are quite varied, and I think this trial has really allowed us to understand more about the trajectories of pregnancy hypertension.
Do you think that there may be a third group of not normal, not hypertensive, but only exhibiting at certain times at home, for example?
Yes. So I think we also see groups with what's known as white coat hypertension, and we know that there were 24% with a clinic diagnosis of hypertension who never recorded a raised home reading. And we also know about the group with masked hypertension who have high home readings and normal clinic readings. And we saw that particularly in the Bump 2 trial of those with a diagnosis of hypertension. So using one label to describe all of these groups is probably not really representing the complexity that is pregnancy hypertension, particularly because clinicians sometimes are unsure of how to integrate home and clinic readings to make decisions about treatment.
And it's my understanding that there is no threshold for a hypertension diagnosis with self-monitoring of blood pressure at home right now. Is that true?
Certainly when we started, it wasn't at all clear what the correct threshold is, and I'm not sure that it is any clearer now. Interestingly, if you take individuals who are pregnant and measure their blood pressure without choosing them in any way, so you just do it on a population basis, you get pretty much the same blood pressure at home as you do in clinic, which is why we chose to use the same target, 140 over 90 millimeters of mercury, for both home and clinic readings. If, on the other hand, you take a group who've been labelled as hypertension, because that labelling is currently done on the basis of clinic blood pressure, what you do is you select for pregnant individuals who are more likely to have a white coat effect. In other words, pregnant individuals who are more likely to have higher blood pressure in the clinic than at home. And so you do get a small difference between clinic blood pressure and home blood pressure of perhaps 5 or 7 millimeters of mercury. So outside of pregnancy, the thresholds are 5 over 5 lower for home readings, largely for that reason. But in pregnancy, it wasn't clear to us, and it certainly wasn't clear to the clinicians that we talked to, what was the appropriate level to be intervening at on the basis of home blood pressure. And we were very keen to be fairly conservative in these trials, because both trials really, as we mentioned, were in the context of an evidence base of 100 pregnant individuals. And now we're doing, between the two trials, over 3,000 pregnant individuals. So it was a very big step change, but one where we felt that we should be reasonably conservative in our protocols.
Let's move on to some detailed conversation about the BUMP 2 trial. Some participants from BUMP 1, as they became hypertensive, were able to move into the BUMP 2 trial. And then you also recruited de novo participants who had chronic hypertension. Did any of the intervention change for the BUMP 2 trial compared to the BUMP 1 trial?
The intervention was broadly very similar, except that we asked them to monitor daily. Some of the pregnant individuals were more familiar with blood pressure monitoring, particularly if they'd had chronic hypertension prior to pregnancy, where self-monitoring of blood pressure is used to some extent. So again, we used a validated pregnancy monitor, which was really important, and the telemonitoring with an app, which relayed a response to the pregnant individual. And if individuals moved from the BUMP 1 trial into the BUMP 2 trial, then they were asked to increase their frequency of monitoring from 3 times a week to daily, so that they had the same intervention as those who had originally been in the BUMP 2 trial.
So as the evidence continues to evolve, you were able to use evidence from a trial published after you planned your study, and you updated your protocol to account for differences in chronic versus gestational hypertension. Could you talk a little bit about that?
We did pilot work for the trials, but we also collaborated with a colleague doing some work, particularly around the BUMP 2 intervention, developing that. We were a little surprised to find that there did appear to be some early differences in that work between those with chronic hypertension and those with gestational hypertension. And so we felt it was important to try and enhance our sample size such that we could essentially do the statistical analysis separately for 2 groups until we showed that they were indeed similar. And recruiting to this trial was actually relatively straightforward, which allowed us to go on and enhance our sample size to greater than we had originally anticipated, which then allowed us to do both groups. Because of the design which allowed individuals to move, as you mentioned, from BUMP 1 into BUMP 2, when they became hypertensive. This meant that particularly the gestational hypertensive group became much larger as the trial went on than perhaps even we'd anticipated.
In this trial, you did not detect any significant difference in the primary outcome, mean systolic blood pressure, nor were there any statistically significant differences in the majority of maternal or infant secondary outcomes. So neither trial provided evidence that self-monitoring of blood pressure during pregnancy, as designed in these trials, impacted important clinical outcomes. How do you interpret these findings and prioritize further research to make sure that hypertension in pregnancy is well cared for?
I think there's a number of possible reasons why we didn't see an impact on clinic blood pressure. We designed the trial with the development of the intervention based on monitoring. We worked with individuals. We developed the app. We know that some pregnant individuals were self-monitoring, even in the usual care group, but the extent of this was not clear until the end of the study. However, we don't think that that would have had too marked an impact, because evidence from outside of pregnancy shows that self-monitoring by itself, without additional aspects of that intervention, does not impact on blood pressure. But I think there were some more complex reasons related to the maternity system. So when a pregnant individual reported a high blood pressure reading, it's worth thinking, well, how does the system respond? What happens? What does a clinician do? Do they up-titrate the medication? Do they just go on clinic readings? And how do they integrate the home readings into the clinic blood pressure? I think this trial has shown us how we might take what has been a self-monitoring intervention into a more integrated intervention, both from the pregnant individual's perspective, but also from the maternity system. It shows that we need to understand about the impact of white coat hypertension and mast hypertension, and to do further work to understand how self-monitoring might impact on clinical outcomes.
Thank you, Lucy. I'm so grateful for you and Richard and the work that you've contributed, the evidence that you've contributed on this very, very important topic. Pregnancies are very common, and unfortunately, hypertension in pregnancy is increasingly common.
I think that's really important to acknowledge what an individual might take away from the experience. It may not be for everyone, but in fact, we had a very small proportion of individuals who declined to monitor because of health anxiety reasons. Overwhelmingly, those in the trial felt that it was a positive experience. They talked about empowerment. They talked about taking responsibility for their health. And I think sometimes the headlines of the trial doesn't always get the pregnant individual's perspective across in quite the same way.
This has really been a wonderful conversation. I'd like to thank Professor Chappell and Professor McManus for their expertise and their contribution. This episode was produced by Shelley Steffens at the JAMA Network. The audio team here also includes Daniel Morrow, Jesse McQuarters, Lisa Harden, Audrey Foreman, and Marilyn Frickeluk. Dr. Robert Golub is the JAMA Executive Deputy Editor. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.